So, good afternoon, students. We are going to finish the localization in CNS, and today we will discuss the CNS case also, right? Last class we have gone through the big picture of the brain, where we said that the anterior part is action, and the posterior part is perception. And then we also discussed about arousal and awareness, and we discussed briefly localization of frontal lobe syndromes. We also discussed about memory, language, and we had problem with the language. We discussed in detail about dysarthria, aphasia, then how to localize visual disturbances. We discussed at length. Then we had some discussion on spatial attention, motor systems, and the somatosensory system. These all we discussed in the last class, localization. And in the second half of that class, we also discussed about the brainstem and cranial nerves, where one confusing statement was made by me that the trigeminal nerve has a lesion which is on ipsilateral, but it's on contralateral jaw deviation, as well as the hypoglossal nerve involvement on side will deviate the tongue to the opposite side. The uvula is deviated to the healthy side. These are the few things which I argued that I was wrong in telling them in a wrong way, but I thought when I reviewed the presentation, I thought that I should correct and tell you people. So today we will be going to spinal cord, and we'll be discussing about the nerve roots, and of course then we'll see the plexus a bit. So the spinal cord, you all know, is 45 centimeters and 18 inches approx. The bony vertebral column protects the spinal cord. The length of the spinal cord at birth, it extends to the lower body of the L3, but at adulthood its tip reaches L1 to vertebral disc level. That means T12, or to the lower border of the L2. Now this is the length. Now look at the diameter. Diameter of the spinal cord at cervical and lumbar regions where the plexus are formed is 13 millimeters, or half an inch. And thoracic cord, it is 6.4 millimeter, 1/4 inch. The anteroposterior and transverse diameters at C2 is 8.8 into 12.4, that is almost 1.2 centimeters. C4 it is 1.4 centimeters. C7 it is 11 centimeter, 1.1 centimeter. So the cervical enlargement is from C4 to C6, and the AP diameter is 15 to 27 millimeters in lumbo-sacral region, and lumbar stenosis is called if it is less than 12 millimeters. So this the diameters you please keep in mind. They are very important to understand. Now, after learning about the dimensions, there are about 31 spinal nerves. 8 are cervical, 12 thoracic, 5 lumbar, 5 sacral, and usually one coccygeal. Okay, what's the problem? Yes, Vaishnavi, what is the problem?
Sorry, sir, that happened by mistake.
All right, okay. So exit of the nerve roots. The first pair is between the skull and the atlas, that is C1, and C2 to C6. They exit above the respected number vertebrae C, and C8 is above T1 vertebrae. So that's the only change. The remaining spinal nerves will exit below the vertebrae of the corresponding number, and the nerves have got a ventral root, a dorsal root. There's a Bell-Megendi law which says that the sensory input is on dorsal root and the motor output is from the ventral root. So both the ventral and dorsal roots join to form the spinal nerve in the intervertebral foramina, and they exit from the foramina and again divide into anterior primary rami and posterior primary rami. The posterior primary rami supply the paraspinal muscles, and the anterior primary rami in cervical region and lumbo-sacral region, they unite to form the brachial and lumbo-sacral plexus, which we have discussed some time back. So that is the anatomy, and you see the cervical, the thoracic, and the lumbar vertebrae. The vertebral bodies are in the anterior region, the spines are in the posterior region. There is the intervertebral foramina through which the nerve comes out, and the spinal cord ends at L1, and of below that is cauda equina or conus medullaris. Right. So the spinal cord has a function. It has got ascending tracts, it has got a descending tract. The main ascending tracts are the spinothalamic tract and the posterior column. If you look at the spinothalamic tract, there is a dorsal root ganglion which is there present here. This is the dorsal root ganglion. Okay. So the dorsal root ganglion, it is a pseudo bipolar ganglion. That means it has got a central process. It also has a peripheral process. The peripheral process is getting the action potentials from the periphery. The sensory receptors, the pain and temperature receptors, those are distributed in the palms and the soles and the whole body. If there is a stimulation, they send action potentials to the dorsal root ganglion. From the central process of this pseudo bipolar neuron, either synapses at the same level or one or two levels above or below in the tip of the dorsal horn, and from there the second order neuron starts and crosses in front of the central canal and ascends up as spinothalamic tract and reaches the thalamus, and from thalamus the third order neuron goes. So that is how the pain and temperature sensation is conducted. That means in spinal cord it is a crossed tract. The ascending spinothalamic tract is a crossed tract. These are important to learn. The proprioception or the vibration, joint position sense, which help in maintaining the posture of erect posture, the balance, the environment, orientation, all these things are conducted through the dorsal columns, and the action potentials that are generated by the kinesthetic responses, the muscle spindles, and the 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 receptors that are present, and something like Pacinian capsules, Merkel's discs, and all, they send the action potentials to the dorsal root ganglion. This fiber, the central process, does not synapse here. It does not cross to the other side, but it ascends up. It ascends up with few tweaks to the nucleus of Clark. It ascends up and goes to the gracilis and cuneatus nucleus. and there the second order neuron starts and crosses to the other side and ascends in medial lemniscus to the thalamus, and from thalamus the third order neuron goes to parietal lobe. So these two important sensations have three order neurons: the first order, the second order, and the third order neuron, which you should remember for localization. And the motor things, you can see the ventromedial region of the spinal cord, and it is supplying the extensors of the trunk and flexors of the trunk. That means the paraspinal muscles, they are in effect supplying the spinal muscles or help in erect posture. The extensors of arms and flexors arm, you can see them here in the ventral horn. Similarly, flexors of forearm and leg, they are all seen here. Flexor of hand and feet, they are seen here. That means central, ventrolateral, dorsolateral, retrodorsolateral. There are groups of motor neurons in the ventral horn, which you can see here. These are the ventral horn neurons which will supply the extensors and the flexors of the hands and the limbs. So ipsilateral, they have the posterior columns which are going up. The contralaterally crossed tracts are usually this is the coming down of motor tract, and this is the spinothalamic tract that is ascending. So crossed at this level, these are crossed at this level, partly crossed at this level, uncrossed at the, so you look at the uncrossed dorsal column is not crossed. It's very important to understand the Brown Sequed syndrome, posterior spinocerebellar tract, and this is the anterior spinocerebellar tract and the lateral spinothalamic tract and the ascending spinocerebellar tract. And see that these are the other tracts which are present here, this spinoreticular tract, and these tracts are crossed and uncrossed. You realize the most important is the posterior columns which is uncrossed, the spinothalamic tracts which are crossed. So you have again to understand better, the upper motor neurons are shown. These are motor which are already pyramids, they have crossed. This is represented by contralateral side, and it is homing on to the anterior horn cells in the ventral horn, and this is the alpha motor nerve going to the muscle and supplying the neuromuscular junction at there. So in essence, the sensory ascending pathways, if you look at that, there is a lamination which you should understand. Sacral, lumbar, thoracic, cervical. SLTC is the posterior column lamination. CTLS is the spinothalamic lamination in the cord. Okay, that's very, very important for us to understand. The pyramidal tracts which are here, their cervical is medial and sacral is lateral, just like spinothalamic tracts. You got some extra pyramidal tracts like rubrospinal and reticulospinal tract and olivospinal and vestibulospinal tracts, and anterior corticospinal tract is situated, it is not crossed, and some fibers are remain. So what are the sensory ascending pathways? Afferent, that are represented in blue, the dorsal column, medial lemniscus system, which the second order neuron starts in gracilis fasciculus and cuneate fasciculus. The spinocerebellar tracts, posterior spinocerebellar, anterior spinocerebellar tracts. The anterolateral system, lateral spinothalamic and anterior spinothalamic, and spino-olivary fibers. These are the ascending tracts. The descending tracts are motor and descending pyramidal tracts. These are lateral corticospinal, anterocorticospinal, extrapyramidal tract, which I just enumerated. So neurological examination of spinal cord, below the lesion, if there is a lesion, there is weakness, there is numbness, there is spasticity, hyperreflexia, and you may encounter autonomic dysfunction in the form of urinary incontinence, constipation, and sexual dysfunction. And as I said, the lumbar enlargement, and after that L1, it is conus medullaris giving rise to cauda econa fibers here. Right? This is a cervical enlargement. You can see in the diagram the diencephalon, the midbrain pons, and some of the cranial nerves come down, and especially the trigeminal sensory part. So the spinal approach is Are there radicular signs and symptoms at the level of the lesion and sensory level at below the lesion, UMN signs below the lesion, and you have to have a comment on bladder and bowel dysfunction. So these are the main things which happen in this category. One, radicular signs and symptoms, sensory level at or below the level, and motor. So UMN signs below, and at the level you have LMN signs. Spinal cord level localizes the lesion, and you should know the key cervical and thoracic dermatomes. You see the C5 is here, C6 in the thumb, C7 middle, C8 little finger, T4 nipple, T10 umbilicus, T12 the groin, and L1. So, patient complains of tight belt sensation at the level of the lesion, and that is called sensory level. Examination at this level shows sensation below the lesion, the level is decreased. That hung level may be seen in syringomyelia, where above and below the sensations are normal, but in between there is a dermatomal type of sensory loss. The lumbo-sacral dermatomes are L1 and L2 and L3 and L4 and L5. So this loss, if there is problem in the dermatomes, that means spinal cord segments or the dorsal roots, what happens is there is an overlap from the surrounding root. That's why there is a partial sensory loss. The lumbosacral plexus gives rise to posterior tibial nerve, sciatic nerve, posterior tibial nerve, common peroneal nerve, in addition to the superior and inferior gluteal nerves. These nerves also can be damaged, and their sensory loss is complete. So you have to differentiate sensory loss because of spinal cord origin, where you get a sensory level below which all modalities of sensation are diminished. The second level of sensory loss is at the radicular level, where in the dermatomal distribution of sensory loss, but there is overlap, it is a partial sensory loss always. The third is the nerve distribution sensory loss, involving the posterior tibial, common peroneal, sural nerves, saphenous nerve, pudendal nerve, the obturator nerve, and you see the sciatic nerve and the inferior and superior gluteal nerve, the femoral nerve. All these nerves are coming from lumbosacral region. Now, as such, you get a long thoracic nerve of bell and supraspinatus nerve and narrow to subscapularis, thoracodorsal nerve, medial antebrachial, medial brachial cutaneous nerve, medial pectoral, lateral pectoral, axillary, radial, median, ulnar, and these nerves also can get affected. Their sensory loss is complete in their distribution. We should know the distribution of dermatomes and also the nerves. That's important. So you see that cross section, see the dorsal columns which are ipsilaterally conducting vibration, position sense, and 2-point discrimination and deep touch to the brain. The corticospinal tract is the motor function signals are coming from the brain which are crossed, and paralysis, paresis, spasticity, hyperreflexia, clonus and Babinski sign. The spinothalamic tract is taking the sense now, that is the contralateral pain and thermal sensations, and the spinal motor neurons, they also cause paralysis, paresis, hypotonia, areflexia, fibrillations, muscle atrophy, all features of lower motor neuron. So if there is a problem here, it is lower motor neuron. Autonomic neurons are also present in the dorsolateral column, which will cause meiosis, ptosis, anhidrosis, and anophthalmos. So the spinal cord brown Sequred syndrome is because of the lamination which we have seen. The ipsilateral signs are UMN signs, loss of kinesthesia and discriminative lower motor neuron signs, segmental, and also autonomic signs. The contralateral, there is loss of pain and temperature. So ipsilateral, if you got a weakness, then you please concentrate on the examination of dorsal columns, that is proprioception, vibration, joint, patient sense. And the contralateral, you should look for pain and temperature. That anatomy you understood clearly. Now, subacute combined degeneration of the cord, corticospinal tracts, and posterior columns are involved. And in this condition, this is the condition of vitamin B12 deficiency, atrophic gastritis, and intrinsic factor deficiency, malabsorption syndromes, ileal resection. Now, all these conditions can give rise to subacute combined degeneration of the cord. And also, anterospinal artery is a preserved posterior columns, and this is the anterospinal artery distribution that supply the spinal cord. The conus medullaris syndrome is the tip of the spinal cord. There is a lesion there. Usually, these lesions are metastatic lesions. There's a carcinoma prostate can metastasize, colon can metastasize, and also rectum can metastasize. So, what they do is a perineal sensory loss. That means symmetric sensory loss in the perineal region. There is a predominant black bowel retention and minimal extremity weakness. Below the corners, the spinal nerves are in form of a bunch called chorda icona. If there is a problem there, then you have pain, asymmetric, bladder bowel immediately in late stage. This will come lower extremity weakness element syndrome. I have to differentiate conus medullaris and chorda icona syndromes if the pathology is in the lumbo-sacral region. The localization of now will go to the nerve roots. So you have to diagnose in the spinal cord whether it is intradural, extramedullary, intramedullary, or extradural compression. You have to differentiate between compressive myelopathy and no compressive myelopathy. Two factors will always help you in deciding this is asymmetry and progression. If the problem started in one limb, gradually it has progressed to the other limb. There were no bladder features initially. When the bladder features have come later, the weakness also has progressed, that is compressive myelopathy. The compressive myelopathies can be extradural compression because of the metastasis, multiple myeloma, pyogenic myelitis, and tuberculosis, spot spines, or various infectious, neoplastic, benign, malignant secondaries, all can cause extradural compressions. The intradural extramedullary is characterized by radicular pains and progressive lesion is caused by two tumors, that is meningiomas and schwannomas. The intramedullary tumors, they present with usually bladder symptoms much before the motor weakness, and those are usually gliomas and ependymomas. So that is a spinal cord. It's a horizontal localization. Vertical localization depends on the most significant sign to decide a vertical localization is the deep tendon reflex. If C5 reflex is absent, lesion is at C5. At that level, you will find lower motor neuron features, and below that, you find upper motor neuron features of spasticity, weakness, and deep tendon jerks, which are exaggerated. Now, lower motor neuron weakness and our sensory symptoms occur in specific patterns in dermatomes and myotomes. So I said you should remember all the dermatomes and myotomes. So you see the here C5 dermatome, C6, C7, C8 dermatome. You remember this, and what are the roots and the movement? C3, C4 are important for diaphragmatic movement. C5 is arm abduction, deltoid, elbow flexion, biceps muscle. And C6, elbow flexion is also biceps. C7 is elbow extension, triceps and wrist extensors is C7. C81 is hand intrinsic muscles, finger flexion, by L3 spinal segment, ankle dorsiflexion, knee extension, ankle inversion, or L4, toe extension, ankle dorsiflexion, knee flexion, and hip abduction are mediated by L5. The plantar flexion, S1, is more important, plantar flexion and hip extension. So these are the important movements all the students should remember to seek to localize the lesions, and this is very important slide. Okay. Right. So we have done it. Now look at the upper limb, the cervical radiculopathy. The pain will be in the distribution of the dermatome. Pain typically radiating from the neck and sensory loss in a dermatomal distribution. Now we learn what is radicular pain here. Radicular pain occurs in a dermatomal distribution. It is a sharp, shooting, lancinating pain. It is aggravated by all the maneuvers that increase intracranial pressure, like coughing, sneezing, and straining while fast passing stool, all because the spinal roots are covered closed by a sleeve of subarachnoid space bathing the CSF. So, whenever intracranial pressure is raised, the CSF pressure increases and the pain gets precipitated. That's the radicular pain mechanism for you. So the dermatomes of the cutaneous area supplied by a single spinal root are shown here. This is the C3 here, this is the C4 here, and the dorsum is C5, this is C6, C7, C8, and T1. So in the region of C3 you can see on the back side of the neck C4 and C5, and you can see the T1, TA, C8. So these are the C3 is angle of jaw, C5 shoulder, C6 digits 1 and 2, digits 3 and 4 C7, digit 5 is C8, T1 medial brachium, T4 nipple, T6 xiphoid, and T10 umbilicus. So the key dermatome maps vary and overlap, can test light touch and pinprick. Pin should be tested with single pokes, not repeatedly. Use face as a control. One poke on face, other. Don't do this repeated. Okay, that's the key. These are the key dermatomes which you should remember. The best way to remember is, one of our teachers used to say, is while bathing you revise your dermatomes. So what are your dermatomes till you learn them properly? You see where S3 is, S4 is, what's on the back side of the knee, is it L3 or is it L4, where is L5? So all these dermatomes are important for localization. That is C2 for you, C4 and C3 you can see behind. This is the C2. There's no C1. Okay, no C1. Don't say any answer when you are asked about C1. This is C3 and tip is a C4. C3 is actually on this area. And you see the C5, it's actually dorsal, and this is a T1, T2, C8, C7, C6, T3, this is the T6 is the costal mark, T10 is the umbilicus, T12 is the groin. You see the L1, L2, L3, these are the points where you have to test for dermatomes. That's why they are shown clearly. This is the L5 region for you, this is the L4 region for you, L1 here, L2 and L3. Here you get genitofemoral nerve, ilioinguinal and iliohypogastric nerve, right? And see the S2 back side of the knee, S1 lateral. This is a S3 dermatome, and near the radiculopathy we have defined already the radicular pain. Most common at L4, L5 are SL, L5, S1. Radiculopathy is common below the knee, L4, L5 or L5, S1. Pain typically radiating from the low back and sensory loss in a dermatomal distribution is seen. So for localization, you should know what are the dermatomes. The thoracic dermatomes are usually involved in herpes zoster. So in the lower limbs, in the upper limbs, we have seen the movement of diaphragm is C3, C4, arm abduction, elbow flexion, biceps, elbow flexion is biceps, elbow extension is triceps, and wrist extension is also C7, C8, T1 hand intrinsic muscles, L2 hip flexion, knee extension, hip adduction is L3, ankle dorsiflexion, knee extension, ankle inversion. Usually inversion is the one which gives you L4, L5 is toe extension, ankle dorsiflexion, knee flexion, hip abduction, plantar flexion, and hip extension. These are S1. So the group of muscles supplied by a single anterior spinal root is called myotome. Please remember all the dermatomes and all the myotomes. So to remember, C5 elbow flexion, C6 wrist extension, C7 elbow extension, C8 finger flexion, T1 finger abduction, that is palmar interossei and dorsal interossei. So the myotomes of upper lobe, the important ones, elbow flexion is C5, wrist extension is C6, elbow extension is C7, finger flexion is C8 and T1. So you can see the various movements or excursions by the upper limb. You can see the C5 helping in the shoulder abduction, and C6 and C7 is adduction. And similarly, the elbow joint is showing its excursions, and is similarly the wrist joint is showing, and along with the digits. In the lower limb, hip flexion is by L2, that is iliopsoas and pectineus muscles. Knee extension is L3, you got quadriceps femoris and all the other muscles. Then the ankle dorsiflexion is L4 and L5 is great toe extension, and S1 is ankle plantar flexion. And you can see the L2, L3 movements, L4, L5 movements, L3, 4 movements, and this L5, S1 movements, this L4, L5, dorsiflexion, S1, 2, plantar flexion, inversion and eversion. So L5, S1 is eversion, L4, 5 is inversion. So there is a symmetry here which you can remember by L4, 5, L5, S1 inversion and eversion, L4, 5, S1, 2 by dorsiflexion, plantar flexion, L2, 3, L4, 5, that is extension and flexion hip region. So these are the important things. The deep tendon reflexes also help you in localization. I said the most important localizing feature for a spinal cord disorder is absence of the reflex. So everybody should practice to elicit reflexes. Triceps is C7, biceps C5, brachioradialis C6, C5, knees L3, 4, ankle is S1, 2. The thing to observe is no L5 reflex. So, but radiculopathy is more common in L5. So, L5, if you want to see if the radiculopathy is there or not, you have to learn to examine hip extension, because the root collateral nerves of inferior gluteal and superior gluteal, if they are involved in the radiculopathy, and there will be hip extension weakness. So hip extension weakness is to be studied. The localization of peripheral neuropathy now. Now we have completed so many things in localization. Now we are coming to peripheral neuropathy. There is a characteristic distal to proximal gradient of sensory symptoms and signs resulting in a classic stocking and glove. This is stocking and glove anesthesia, and symmetrical sensory predominant symptoms. Weakness initially noted in distal limb muscles, and this is the distal limb muscles are initially, this is the place where it starts. Hyperesthesia, decreased sensation, absence of superficial pain. These are the characteristic features. So here we'll learn what is a large fiber neuropathy, what is a small fiber neuropathy. The large fiber neuropathy is fast conducting nerves. These are alpha nerves. They got fast conducting nerves which conduct electrical signals negative hyperesthesia, decreased sensation, anesthesia, lack of sensation. So these are the sensory symptoms that are present. Light touch, large fiber content, vibratory sensation, large fiber, temperature and pain, small fiber, motor, large fiber, reflexes, large fiber. So large fiber neuropathies where demyelination occurs the saltatory conduction through node of Ranvier is disturbed, what happens? There will be weakness, absent reflexes, and there is impairment of posterior column signs like vibration and joint position sensation. These are large fibers. The temperature and pain sensations are slow conduction fibers. So your pain lingers on for a long time. Real small fibers are free nerve endings that are present in the arms, the hands, and the feet. If they are disturbed, you get a continuous burning sensation or burning feet syndrome. There, the touch and temperature and pain are preserved, but you got severe pain. These are real small fiber neuropathies. There are two principal syndromes in neuropathy. You should remember large fiber neuropathy, sensory symptoms and signs, reduced or absent reflexes. Small fiber neuropathy, there are lot of sensory symptoms but normal reflexes. So localization is the neuromuscular junction. Now we finished the localization of the nerves. Now the proximal muscles more than distal weakness is the myopathy luxury. This is episodic, and neuromuscular junction problems are always episodic. There'll be fatigable, worse late in the day or after exercise. Chap who develops diplopia in the evening, he becomes miserable by evening. There is extraocular and bulbar weakness. There are no sensory symptoms. Presynaptic or postsynaptic dysfunction can give rise to neuromuscular junction type of weakness. The localization to the muscle causes dysfunction, causes proximal weakness more than the distal weakness. Here the weakness is not fatigable. There are no sensory complaints other than possible myalgias. There may be hair, chair and stair weakness, which that means you cannot comb your hair because of proximal weakness in the arms. You cannot get up from the chair because of the gluteal muscle and proximal muscle weakness. You cannot climb stairs. So all these features, all three will tell that it's a muscle problem with the preserved reflexes. So that finishes the localization. We'll go through the case sheet. What this case sheet you please download and adhere to it in your examinations. You see the normal name of the patient, sex, occupation, address, hand dominance, followed by the presenting complaints and duration in patient's words you have to write. Note in scientific words, and after that, write the onset of disease, the progress of the disease, and present condition. Then you go on to the history of presenting complaint. The medical terms are permitted here, but avoid if avoidable. You have to do a localization history first, followed by etiology history. You enumerate, you recollect the neurological symptoms that can be present, which are referable to spinal cord dysfunction like weakness, sensory disturbances, bowel bladder disturbances. They're referable to cortical dysfunction like language, memory, seizures, apraxias, agnosias, geographical orientation. Some symptoms can referable to brainstem dysfunction. Symptoms referable to raised intracranial pressure like headache, vomiting, visual disturbances. Referable to cranial nerves like smell, vision, feels, diplopia, facial numbness, dysarthria, dysphagia, nasal degustation. Subject to sensory disturbances, psychiatric disturbances, hallucinations, and delusions. So all these symptoms can be a presenting feature in various combinations or in isolation in patients coming to neurology OPD or to medicine OPD with neurological complaints. And then you record the symptoms which are referable to other systems also, because that's very important. Other systems have a repercussion on the brain. You may have to ask about the hemoptysis, the nocturnal paroxysmal nocturnal dyspnea, the shortness of breath. You may have to do NYHA classification, feature suggestive cardiac failure. You have to take the history. You have to take the history of hemoptysis, breathlessness, and bronchospasm, and hematemesis, melena. You got dysfunctional bleeding, menorrhagia, metorrhagia, and all these things which you have to give a cursory glance and identify if there is a problem there, which we'll have to tackle. And history of past illness, similar reports earlier, head injury, and personal history, you all know how to take that. I'm not going to go into this, but family history I want to emphasize. You have to have a family tree diagram of at least 3 generations, draw a family pedigree chart which you have to practice by learning. Then you give medication history, then the present functional status you give, whether he's ambulant, bedridden, ambulant with support, and whether he's got a waddling gait or what type of high stepping gait, and you write what is the functional. Then at the end of the history, you should summarize the case and give your four-tier diagnosis. Functionally, whether the patient has quadriparesis, hemiparesis, monoparesis, diplopia, etc. Physiologically, you identify with the symptoms what are the tracts and nuclei, etc. that are involved. Anatomically, you localize in spinal cord horizontal and vertical. Similarly, you localize anatomically where is the problem, and you hypothesize what could be the pathological and etiological and right here. So this part is very very important. Most of the times the diagnosis is made by this phase only. So you have to take history, you have to elicit what all points I have mentioned here. Then you go to the general examination, you record the vital parameters, pulse rate, blood pressure, temperature, respiratory rate, peripheral pulses, skin changes, lymphadenopathy, trophic changes, neurocutaneous markers like capillus spots, hemangiomas, tuft of hair, dermoid, myelomeningocele, dimples, lipomas, right, pilonidal sinus, etc., subcutaneous nodules, and skeletal examination and peripheral nerves. You can do it here or there. Then you got to do systemic neurology assessment, systemic examination of cardiovascular, respiratory, GI systems before neurological assessment, because neurology suffers dysfunction from these systems. Also, neurology suffers. So first, rule out any dysfunction there, and then go to neurology. Start with intellectual function, where you will consciousness, memory and judgment, intelligence, hallucinations, delusions, orientation to time and place, dominance. If you have time in relevant cases, do MMSE examination, mini mental status examination, which has got orientation to time and place and registration, attention calculation, recall and language functions as tested by identification of small objects and repetition, three-stage command, and ask him to read and obey, that open your eyes and things like that in MMSC examination. Then you zoom on to the speech next. This is dysarthria, type of dysarthria, which we mentioned. Is it lingual, labial, guttural, or is it extrapyramidal, cerebellar, spastic? And so you concentrate on seeing whether the individual has dysarthria or aphasia by asking, can he speak himself, can he understand, can he recognize common objects, can he read, can he copy, and you see spontaneous speech output, comprehension, repetition, writing, reading, and naming, all to be tested in quick succession. The second, now you test for acuity of vision, Snellen's trap, finger counting, the light perception, and you do the field of vision from 3 feet distance, minimum one hand stretch at least, tree confrontation method, color vision, red, green, yellow, blue, total blindness, affected in lesions of occipital cortex. The red color distortion is very common in multiple sclerosis and demyelinating disorders. Then third, fourth, and sixth oculomotor trochlear abducens nerves can be tested by movements of the eyeball from 2 feet distance, pursuit, saccades, convergent, divergent eyeball movements, and these are called the coordinated movements and conjugate eye movements. And individual eyeball movements, you look for nystagmus, horizontal, vertical, rotatory, pendular, jerky. Diplopia, does it improve after closure of one eye? Then you look for light reflex, direct, indirect, and accommodation reflex, pupil size and shape, and ptosis. The trigeminal, sensory over the face, masseter, temporalis, pterygoids, testing for motor, and you look for the deviation of the jaw, which is to the opposite side of the lesion. When there is a fifth nerve dysfunction, use wooden spatula or involvement in upper lower half. In upper motor neuron, the upper half of the face is spared, only the lower half is involved. We look for occipital-frontalis, palpebral fissure, tabularis oculi, nasolabial fold, blowing out cheeks, angle of mouth, hyperacusis, taste sensation of 2/3 of the tongue, And if there is any auricular herpes, then you have to diagnose Ramsay-Hunt syndrome. Vestibulocochlear nerve, rat and chest, test, Rinne's test, Weber's test, caloric test. You identify whether air conduction is better than bone conduction. Conduction. Air conduction better than bone conduction. The glossopharyngeal specific test is taste sensation on the posterior one third. Vagus position of the uvula, gag reflex, taste posterior one third of the tongue, laryngoscopy for vocal cords. Of course, the elevation, the movements of the soft palate movements, whether a movement of this palate is equal on both sides or not. The accessory nerve, and you ask him to lift the shoulders and shrug the shoulders to test the sternocleidomastoid and trapezius sternocleidomastoid by asking the individual to turn his face to one side and depress your hand with the jaw so that you can prominently see the sternocleidomastoid on the other side. The motor system examination consists of nutrition of the size of muscles. There is whether you notice whether the resting of localized or generalized in nature, hypertrophy is there. The muscle tone, resistance to passive movement at various joints, hypertonia or hypotonia. If it is hypertonia, then again you comment whether it is rigidity, cogwheel, and lead pipe or spasticity. Then power of the muscles you test and test at various joints, and you grade the power as 0, no contraction, 1 flicker of contraction, 2 active movement with gravity eliminated, 3 movement against gravity, mild resistance, movement against gravity with moderate resistance is 4, and active movement against gravity and full resistance is 5. So then you do the coordination of the movements. Upper limbs you do finger to finger test, lower limbs knee heel, and finger to nose test and Romberg's test. And involuntary movements of tremor, finer course, chorea, ethetosis, chorioethetosis, myoclonus, tics and habit spasms are looked for in this case. Then you look for sensory system, subjective and objectively, the superficial sensations of touch, tactile sensation, localization, pain, temperature sensation, and deep sensations of joint sense and vibration and sense of position, combined sensations, cortical sensation, that is stereognosis, 2-point discrimination, graphesthesia, trophic changes are observed like hyperkeratosis and and there may be ecchymosis, ulceration, infection, and then C is Romberg's test. So you remember the occiput is dermatome C3, shoulder C5, middle finger C7. This is very important. Then you look for reflexes: corneal, conjunctival, parietal, pharyngeal, abdominal, upper epigastrium T6 to T9, mid T9 to T10, epigastric T11 to L1, premasteric, plantar L5, S1, S2. Grading of the reflexes, you do sluggish, normal, exaggerated, and you have upper limb, biceps, triceps, supinator, lower limb, knee, and ankle, and latent reflexes, Hoffman's, Rosselimos, Wartenberg's, and you look for clonus, patellar, ankle, visceral, and deglutition. You may have to comment on the bladder again if you want. Precipitancy, retention with workflow, incontinence, whether urgency, precipitancy, frequency is there, bowel and sexual function comment. So this is an extensive case sheet which will help you in remembering. Then you look for the cerebellar signs, nystagmus, hypotonia, intention, tremor, dysdichokinesia, rebound phenomena, pendular knee jerk, and dysmetria, past pointing. Then also you have to do a bit of extra pyramidal testing also, whether the rigidity is associated with fatiguing, and you extra pyramidal test thing which I have not mentioned in this. You have to do rapid alternating movements, you have to finger taps and the hand grip movements, the toe taps, hypomimia, these are observed for the rigidity. And if you ask whether there is any cogwheeling in the wrist, because cogwheeling is present when the tone is increased and there is associated tremor, you see cogwheeling, then you look for pronator catch for the rigidity. Rigidity is resistance on both directions, and you won't encounter in one direction only, it will be in both directions, but whereas the tone is only in one direction, it is velocity mediated. So then you look for the signs of meningeal irritation, peripheral nerves whether they are thickened or not, spine and skull for any tenderness, spasm, gibbous, and other deformities, You auscultate over the eyeball, suboccipital region, bilateral, parietal, and temporal regions. You look for the gait examination, what type of gait, spastic, cerebral, Parkinsonism, high steppage gait, or any other characterization. Then your final four-tier diagnosis. Functionally, physiologically, anatomically, pathologically, what do you think, and what investigations you would like to do in a particular case, you have to plan at this stage. So that finishes our examination and case sheet writing. This case sheet is going to help you a lot. If you read it thoroughly, you memorize it, you try and implement, examine number of patients, the 1,000 fundoscopies will make you do a fundoscopy correctly like that. If you elicit deep tendon jerks every case, you will become a master at some time. But only key point is you have to pay attention and examine the patient, right? Don't shy away from examining the patient. Are there any questions? Do you want to ask any questions? You can unmute if you want. If there are no questions, then shall I close? Or you want to ask something, you want to ask? I'm still got few minutes. Somebody can talk. Did you learn anything new? Oh, more than 100 chaps are there on presents. Surprise, nobody talks. Chalo, in that case, just go through the presentation and let me know if there is anything which you want to understand, and I can come back and tell you in a forum, whether email or WhatsApp or whatever it is. So I'm ending the presentation. Thank you very much. Have a good day.
Thank you, sir.